Hello and good evening to all of you. So we are going to start a new module today, and that is subfertility. It is a small module, and the subfertility history is slightly different. And we are going to see how it is. Anyway, there is no ready-made template for anything. Like your history taking will also be either focused or detailed history taking as per the scenario. So like in these stations, you will get stations you will get related to the female subfertility, like the famous ones we have polycystic ovarian syndrome and tubal fertility factors, where that scenario is of bilateral tubal spasm, endometriomas, and endometrioma is a hot topic these days because there is a new talk, there is a new NICE guideline, an ESHRE guideline. Fertility preservation options, the talk came, and then this scenario came in the exam. OHSS, very hot topic. It comes in every exam. Reversal of sterilization. And male factor infertility, we have two very famous stations, azoospermia, and where the male is taking steroid. And the patient safety points are like you have to maintain the confidentiality of the patient, and you will be having the results, so correct interpretation of the result, and not disclosing the result to either of the partners without their permission. Maintaining their confidentiality is utmost important. Okay, so let's begin our session today. As usual, who will come? Dr. Shweta, you will start, huh?
Yeah,
Okay, that's good. Okay, any random station for you? I'll just take something for you. Okay,
yes.
take you 2 minutes. You have 3 slides.
Mhm. Yeah, next paper, please.
Yes.
Next slide.
Mhm.
Yeah, next slide, please.
Yes.
Yeah. Can I start?
Sure. If you're ready, start, please.
Yes. First slide, please. Yeah.
Yes.
Okay. So I'm Dr. Sweta, one of the doctor in Gynae Clinic today. Am I talking to Janet Smith, 34 years old?
Yes.
Can I call you Janet?
Yes.
Janet, I understand that you have been referred by GP because you have pain during period and you have been planning for baby for 2 years. Is it so?
Yes, actually, I don't know what is happening to me for the last 6 months. The pain has too much increased during the periods, and I'm not
Mhm.
able to have a baby.
Okay, don't worry, Janet. We as a team are here to support you. And I have your report with me also, but I will discuss about that later on. So, may I ask a few questions to know more about your condition? Would that be fine?
Yes, that's okay.
Okay, can you tell me about your pain in your own words?
Oh, yes, actually, I have the severe pain during the periods, and the periods have
Mhm.
really become very painful. And
Mhm.
these are like for the last 6 months, the pain has increased too much.
Okay, can you score that pain in the 0 to 10 scale?
Yeah, around 7 to 8.
Hmm. Have you taken any treatment for that?
Yes, my GP gave me some medications, tranexamic acid, and one more acid. I took that for 3 to 4 months, but there was no improvement.
Mhm. I can see that. I'm really sorry to hear all this, Janet. So, is it related to your period? Like it starts with period or before
Yes.
that, or when does it stop?
Yeah, it starts with the periods and it goes on for, I think, 3, 4 days.
Mm-hmm. Okay.
And it is
So,
only during the periods, not at other times.
okay. Is there any problem with your water work and bowel?
I think yes, bowel opening is a bit painful.
Have you noticed any blood in urine or stool?
No.
Okay. So, since when you have been planning for pregnancy? May I know that in your own word?
Yeah, we are together for the last 4 years, and
Mm-hmm.
since that time we are planning. I mean, initially I used contraceptives, but for the last 3 years we are planning to have a baby.
Mm-hmm. Okay. So, Janet, may I know about any other pregnancies before?
No,
Okay. And what about your partner? Has he fathered any children earlier?
no,
Okay. So, when was your last period? May I know?
10 days ago.
Okay. So, any medical illness for which you have been visiting your GP regularly?
No,
Any other surgery done in the past?
no.
Okay, is your partner fit and well?
Yes, he is.
Okay. So, some of my questions are personal and intrusive, but I need them. May I go ahead with that?
Yes,
So, is there any problem in sex?
yes. Sex has become painful for the last 6 months.
Okay. So, have you consulted anyone for that earlier?
Well, I that is why I came to my GP and he did so many tests for me.
Mm-hmm. So, how many, what is the frequency of your sexual intercourse?
Before it used to be 3 to 4 times a week, but now because of pain, it is two times.
Any sexually shared infection in the past?
No.
Okay. And I can see that your height weight ratio is 24. May I know about your partner's height weight ratio?
Yeah, same like me, 24.
Mm-hmm. Okay. So, do you smoke?
No, I have quit smoking completely.
Okay. Do either of you and your partner drink alcohol and recreational drug?
No, alcohol occasionally, but no recreational drugs.
Okay. So, how is the support at home?
Yes, my partner is supportive.
Okay. And what is his job involved?
Yes, he's a lecturer.
Okay. So, how is the like mood your mood these days? Like, any feeling low down?
No, not low down. I'm a bit concerned that what's happening to
Yes.
me. Is there any serious problem?
Okay, I can understand that. So, Janet, I need to examine you in presence of chaperone and your tummy, feel tummy and down below as well. And I can see that your observations are normal and all of your tests are with me. I have confirmed your name and NHS number. It belongs to you. And I can see that you have come alone. So, your partner didn't come today?
No, no, he is busy. He has classes going on in the university, so he didn't come.
Okay, so Janet, I have your report as well as your partner, but uh, so I have your report with me,
Yes.
and your yes, the blood test which was done for you to see that quality and quantity of egg reserve that seems to be normal, and your the tube test which was done that also seems to be normal, seems open and but I have some concern regarding the scan report. Are you with me?
Okay, what is that?
Scan report shows that there is a cyst inside the ovary. We call it is called endometrioma, and size is big. It is of 5 centimeter. Have you heard of what endometrioma earlier?
No, I don't know.
So actually, let me explain to you. Actually, what happens that during period, inner lining of womb sets every month, and then period happens. But sometimes this inner lining tissue deposits any other site other than womb, like in ovary, like in tube, and in tummy as well. Okay.
Mm-hmm.
So this bleeding happens at each month during the period time, and it gets trapped into the sac-like structure forms and the cyst forms. Are you with me?
All right, yes.
And in your case, it has developed into the ovary, and it is both into the both ovary. So this is the concerning uh, thing.
Mm-hmm.
So regarding the further management, as this is a team of specialists usually take care of this, like consultant gynecologist, fertility specialist, imaging doctor, some and some specialist nurse. And regarding the management, actually, I can see that you are concerned about you are planning for baby. Am I right?
Yes.
Okay, so during this, actually, in this condition, there are three options like wait and watch and medical treatment and some surgical treatment. But wait and watch is not suitable for you because you are planning for pregnancy and the size of cyst is also large. And the medicine would not be suitable for you because it is a hormone which which stops the egg release. But you are planning for pregnancy, so I am afraid this is not suitable for you. Okay.
Right.
And the best suitable option in this condition is the surgery. And the surgery is actually a high risk surgery in this case. It is done by expert hand. It can be done. Let me explain you about the surgery. Do you want me to explain that?
Okay, how it will be done?
It is done actually. It can be done with keyhole surgery, but if required, if it is not possible, then in that case, open cut surgery might be required. Are you following me?
Okay, yes.
Okay, so keyhole surgery is actually done. The before surgery, there are planning is done with a team of specialists like general surgeon, the bowel surgeon, the waterwork surgeon, and anesthetist to see the suitable type of anesthesia. Generally, it is done after putting you to sleep. Thin camera like telescope is inserted through the belly button to look into the pelvis, and the surgery is done.
Mm-hmm.
uh, am I clear so far?
Okay.
As this is the endometrioma, the it can affect other organ also. It can get stuck to the bowel, bladder. So very expert surgery is needed for that. So a team of surgeon would be involved in the surgery. Okay.
Yes.
And even and after the surgery also, and as you are planning for pregnancy, the I'll refer you to the fertility specialist. Before that, they can assess you regarding the ovarian reserve. And sometimes they can advise that egg can be collected before the operation. We call it egg cryopreservation. Have you heard about that?
Yes, I have read a little bit about it. So why
Okay.
will I need that in my case?
Usually what happens that does because this cyst is in ovary, that can damage the ovary tissue as well. Okay, so if
Yeah.
it regarding the surgery also, there are chances that ovarian tissue can be damaged, so that can hamper the fertility and egg quality and quantity as well. So for that thing, fertility specialist may advise you to go for egg cryopreservation before that. Okay.
Mm.
And even after the surgery, the egg quality and quantity reserve would be checked by doing the hormone test and scan as well.
Right.
So after the surgery, if it is just wait, and you can try for pregnancy for 6 months. If it is possible, then very good. And if it is not possible, then after 6 months, we will refer you to the fertility specialist for test tube baby. Uh, are
Okay.
you with me?
Yes, yes. Okay. And after the
Okay.
surgery, is there chance that the cyst can come back again?
Yes. Yes, there are chances that it can come back again, but the repeat surgery is usually not advised. And success after the surgery is 75 in 100 cases, pregnancy can happen after that. Okay.
Okay. Right. Time is up. Now I have one
Yes,
question.
so I'm
Yes.
giving you the patient information leaflet and then connecting you to the fertility specialist and then decide about the like surgery and let us know about that. I'm speaking with my consultant as well.
And I
Any
have,
other concern?
yes, can you tell me my partner David's report? How is the semen
Yes, actually,
analysis?
I have your report, but due to confidentiality issue, I will not discuss about it. Next time when you come with David, we'll discuss it together.
Good.
Okay?
Fine. Yeah. Thank you.
Okay. Okay.
Okay. Well done, Shweta, I must say. Well, very long station, I know. You have to discuss a lot of
Yes.
things.
But I think, what about time?
Did that. You finished one question I asked later on that will the cyst come back
Yeah,
again?
I
But
thought I'll speak at that time only, but I didn't see that slide that time. That's why
no, I did
I
not
thought.
intentionally put
Okay.
that slide. I just showed you
Okay.
three
But
slides.
I was recalling.
Three
Yeah, I
slides.
tried to recall that one, but it was
Yes,
not there.
yes.
So,
No, no,
mm.
no, no. Okay, because semen analysis was done, the reports are attached, but I did not show it intentionally. Okay, because I wanted to ask that question in the end. Okay. So if in the exam all the reports are there, then of course you're going to say yourself that I have your and your partner David's report here. But I will be discussing only your report. Like you were going to say that sentence, I knew. And regarding your partner David's result, due to confidentiality, we will discuss when your partner is here. Okay, well done. Otherwise, so good one. Actually, endometrioma is a very hot topic these days, so you might get any scenario on this one. Okay, so let's discuss the answer. Hello, I am Dr. Shweta, one of the doctors in the gynecology clinic today. May I confirm your name and age, please? How may I address you? Thank you, Janet. I understand that you have been referred by your GP as you're having painful periods and also planning for a baby. And you are here to discuss about your results as well. Am I right? And like subfertility stations, somewhere you can say either like when you are just starting your consultation or somewhere in between when you realize, just ask, I can see you have come alone and your partner is not with you. May I know why? So in the exams scenario, like, of course, there will only be one role player. This is a good idea to ask because we know that in the subfertility, we should see the couple together. That is why. So if she tells you all the story in the very beginning about her pain and planning for baby, so yes, you will be a little empathetic. Yes, I can see that you're going through a really difficult time, and we as a team are here to help and support you. Is there any other concern and expectation from today's meeting? So in a moment, I'll try to address all your concerns. Before that, is it okay if I ask you a few questions and then discuss all the results and discuss the further management plan? Will that be okay? I shall also give the written information leaflet about your condition and write back to the GP about our mutually agreed care plan. Can you tell me more about your periods? And do you have pain at other times or only during the cycle? Have you taken any treatment for pain? Is there any improvement? And how will you um, scale the severity of pain on a pain scale of 1 to 10, where 1 is mild pain and 10 is severe pain? So if she says 7 to 8, so yes, I can see that it is really like pain is too much for you. And is it affecting your quality of life? How are you coping? How about your waterworks and the bowel opening? Because we know in endometriosis, there can be dysuria and dyschezia. When was the last periods? And any bleeding in between the periods? Any bleeding after sex? Are you updated with your cervical screening? And have you been using any birth control method? So cervical screening and all these are normal questions which we are going to ask. Sexual history, always after signposting, I would like to ask you some personal questions. Whether you or your partner were treated for any sexually shed infection in the past. And I can see that both you and your partner are trying for a baby. So did you take any treatment before regarding that? How many times do you have sex in a week? Are you both aware of fertility period? Any problem during sex, like pain? So she told you about dyspareunia, okay? And yes, if she says that, then of course you will be again, you will acknowledge that and you will say, yes, I can see sex is painful for you. So did you discuss this with your partner and what was his response? So yes, my partner is very understanding. May I know, have you ever been pregnant before? And what about your partner, David? Has he fathered any child? Are you following GP for any other medical condition? Are you on any medication? Have you started taking folic acid? Any allergy to food, drug, or metal? Any surgery on your tummy or down below? Any family history of concern, like anyone in family with painful periods or any fertility issues in family? Then occupation history, partner and supports, and smoking alcohol. Yes, you can ask regarding both the partner together. May I know, do you or your partner smoke or drink alcohol? Pardon me to ask, any recreational drugs? And how have you been feeling lately? Have you been feeling lower down because of your condition? If she says yes, then ask her, would you like any help regarding that? If so, we can put you in touch with our counselors. If no, then it's okay. If a little bit of concern, then it's okay. No need to put her in touch with the counselors. And I can see your weight height ratio is 24. What about your partner's weight height ratio? Is he generally fit and well? Okay. May I know your blood group? Thanks for these informations. Would you like to add anything important? Quick examination in face-to-face exam. Okay, so I would like to examine you with your permission and in the presence of chaperone, just to assess your general well-being. And I would like to get a feel of your tummy, assess you from down below to assess the severity of pain and the neck of womb and the womb itself. Will that be okay? Now, coming to your reports, I have confirmed your name, date of birth, and NHS number. Do you have any idea about the results? Blood test was done to check the hormones, and they are normal. It means you're producing eggs every month. And ovarian reserve was checked, which is normal. Ovarian reserve means the number and quality of eggs produced, and they are normal. Another test was done to check your tubes. So tubes are patent, they're working normally, there is no blockage at all. But I have some concerns regarding the ultrasound. The wombs and tubes are normal, but there is cyst in the ovaries, which is about 5 centimeter in size, and we call it as endometrioma in medical terms. Have you heard about it? So in the exam, if the scan report is given, you can just show it to the role player and you can tell her, see, this is the scan report, this is the womb, the tubes and the ovaries. Womb has an inner lining which bleeds every month and we have periods. Sometimes cells of inner lining of womb are found outside the womb, like in the tummy, around the womb, or like in your case, they are found in both your ovaries. They bleed every month during periods. This blood has nowhere to go outside. It gets collected inside the ovary, forming the cyst. And we also call it chocolate cyst of ovary because of its dark color as it contains the blood. And this type of cyst can damage the ovarian tissue, can cause excessive scar formation in tummy, pelvis, around womb, tubes, and ovaries, and this can cause severe pain and also can interfere with your fertility. Am I making sense? Any questions? So is it okay if I discuss with you about the management plan? So it's going to be a shared care involving my consultant, fertility specialist, endometriosis specialist services, including the bowel surgeon, waterwork specialist, specialist nurse, and the GP. So this one I have taken from the new NICE guideline involving the bowel surgeon because there can be anorectal endometriosis as well as bladder can be involved. So we have to involve the bowel surgeon and the waterwork specialist. And if you will take all these names, communication with colleague will be 2 by 2. All right, so we have conservative management, that is wait and watch policy, but this will not be helpful as your cyst is quite big and you're planning for a baby. There are some medications. These are hormonal tablets or injection. Again, they will not be helpful in your case because many of them are birth control methods. They will stop the release of eggs from the ovaries. So we have the surgical method like removing or draining the cyst and removing the scar tissue in the tummy and pelvis. So is it okay if I discuss with you about the details of the surgery? So now here I will just explain one thing that I have added draining the cyst also because this is given in the new NICE guideline. What the NICE says that removing, that is cystectomy, will increase the risk of damage to ovarian tissue, but reduces the risk of recurrence. Draining the cyst, it will have less damage it will cause less damage to ovarian tissue, but there is more risk of recurrence. So they are both the options available. So the like woman will decide, and of course the MDT will decide which will be suitable for her. So these are the possibilities. So surgery will, like first we are going to offer you the keyhole surgery done after putting you to sleep, done by the expert. And it is done meticulously to avoid any damage to ovarian tissue. And if keyhole surgery is not possible, then yes, we may have to offer you the open surgery. What is the benefits? That after removal of the cyst or even after drainage of cyst, your pain will improve. The chance of having a baby will also improve. But there is a risk of surgery like pain, infection, damage to the bowel, bladder, and blood vessel. Now, in her case, you have to talk about damage to ovarian tissue, very important risk for this lady because she wants to have a baby, and decrease in ovarian reserve, that is decrease in the number and quality of eggs. Now, that is why what we have to do, now you have to think what I'm going to do for her before the surgery and what should be done after the surgery. So this is like a sandwich plan. You talked about the surgery. So now, what will be the pre-surgery plan? So before the surgery, as there is risk of ovarian tissue damage, we would like to refer you to the fertility specialist and to check for the ovarian reserve. And at the time, the fertility specialist will also discuss with you about egg preservation. For that, some medications will be given to you so that the ovaries will release egg. The eggs will be collected and preserved, and they can be used for having test tube baby later on. Post-surgery plan, that after the surgery, again, we are going to check the quality and quantity of eggs. And if we see that surgery went on well, there was no ovarian tissue damage, you can try for natural pregnancy for 6 months after the surgery. If still you don't conceive, then we will refer you to the fertility specialist for test tube baby. But if there was complication during surgery and there was ovarian tissue damage, in that case, we are not going to wait and refer you to the fertility specialist, but test tube baby straight away. Okay, any questions? Doctor, can the cyst come back again? Yes, cyst can come back again. And if it happens that repeat surgery is not done, because with repeat surgery, there is more risk of damage to ovarian tissue, and the pregnancy rate is only 25 in 100. So it is recommended to have IVF after primary surgery because here the pregnancy rate is slightly more, 75 in 100. Any questions? All right. So I will be arranging appointment with the consultant in 2 weeks' time. Appointment with counselors if she's very upset, support group number, contact numbers. You can say a few lines in these stations that you can come with your partner and we would be happy to see you both together. Any questions? Okay. Now there was some confusion when we were discussing this endometrioma. Here actually, if patient has endometrioma more than 3 centimeter and severe pain, any patient in pain, we will offer the surgery and discuss about all the pros and cons, and egg preservation is very, very important. So here I will go with this one. Yes, key messages in management of endometrioma in women who wish to preserve their fertility. Like in our patient, she wanted to have a baby. So if the patient has pain, consider urgent need for surgery. And what has to be done? Consider oocyte cryopreservation prior to surgery. So for that, we are going to refer her to the fertility specialist. Ensure minimal damage to normal ovarian tissue. Avoid repeat surgery if there is any recurrence. Fine. Now, this is from the new talk. One thing is very clear in all endometriosis, there is no role of medical therapy because they are all all of them are contraceptives, right? Hormonal suppression is contraceptive. So it is a big no in all type of endometriosis. Even in endometrioma, we don't give it. Only Dynogest is there because this has lesser impact on AMH. And it will reduce the pain, that's all. Now, regarding the surgery, in minimal or mild endometriosis, yes, we can offer it because it will increase chance of natural conception, okay? And it could be considered in good prognosis patients. So again, You have to check everything in the exam, whether investigations are given, what is the age, how is the ovarian reserve, tubal patency, semen quality, everything is okay. Now, in moderate or severe endometriosis, surgery is not the first line if the patient is asymptomatic. Okay, because it may increase the natural conception, but ART has a greater chance of success. So if any scenario comes in the exam where the patient is asymptomatic, she is painless and she wants to conceive, even if it is moderate or severe grade 3 or 4 endometriosis, the first thing which you will say is that we would, as you're planning to have a baby, would like you to refer to the fertility specialist because to have a baby. In your case, we don't offer surgery routinely because there is no evidence that it will increase the success rate of having a baby. Why? Because it is considered in symptomatic women with previous failed IVF. Also ask whether you had any children or any previous test tube baby. Surgery will cause reduction in ovarian reserve. If there is endometrioma, and even endometrioma is not not so much painful. Endometrioma is there, maybe accidentally found or whatever it is, or mild pain. In that case also, what they say, if it is up to 3 centimeters, less than 3 centimeters, you can refer to the fertility specialist first. Cystectomy will cause reduction in ovarian reserve. The only advantage of cystectomy is, as we discussed, it will prevent recurrence. Routine cystectomy does not increase live birth with ART. Now, when we will consider surgery, suppose oocyte retrieval is difficult because of the excessive scar tissue formation, only then surgery is considered. Now, I'm coming here directly. Our patient had endometrioma more than, it was 5 centimeters. Endometriomas, any endometriosis, there is very bad environment. There is so much of inflammation over there. Environment is very toxic. So they already have negative effect on the oocytes collected. And further cystectomy increases the risk of poor ovarian response to stimulation. So it has to be a joint decision. At the same time, you're going to say that since you're having the cyst and there is also chance that it can rupture, it can twist on its own, or it can even bleed. So after the treatment, after we refer to the fertility specialist, then we can decide upon removing the cyst. But if it is a big cyst and if she's in pain, then first we have to remove the cyst. When we refer the patient for assisted conception, so if it is moderate to severe, it is associated with lower number of eggs retrieved and reduces live birth rate after ART. So already because of the toxic environment, ovarian reserve will be less. That is why we have to check the ovarian reserve in these patients. This is again from the new talk. What they say here, avoid ovarian cystectomy prior to ovarian stimulation unless indicated for pain or access to ovary or oocyte retrieval. So if the station is clear-cut, 5 centimeters endometrium, or even if it is 3 centimeters and patient has severe pain, then first thing is that we have to offer cystectomy and talk about ovarian tissue damage. So we have to discuss about the ovarian tissue reserve checking. It will be there in the exam. Ovarian tissue reserve will be given there, and you have to talk about the egg preservation. Okay, so I hope there won't be any confusion if you get the scenarios in either ways, painful or painless. Fine. Okay, Shweta, well done.
Ma'am, can I ask one question?
Yes, yes, yes.
Well, suppose the patient is painless, but it's 5 centimeter without any symptoms, then we'll do cystectomy, no?
Yes, 5
No
centimeters. See,
Ah.
3 centimeters and above, there is role of cystectomy. If it is painless,
Irrespective of symptoms.
if it is, yes, that is irrespective of symptoms. That is for the patient who is not planning for a baby, but where the patient is planning for a baby. First thing we have to say that yes, this big size needs surgery, but with surgery, there is risk of ovarian tissue damage. So we can refer you to the fertility specialist. And then they will discuss with you about the egg preservation also. So you have to discuss the pros and cons. Painless patients, there is no role of routine cystectomy. That is the thing. If I'll go back here. Cysts more than 4 centimeters, first line is surgery. Yes. But at the same time, you have to discuss the pros and cons of the surgery, that it will cause ovarian tissue damage. My role and your role is to discuss about the surgery. Yes, it is required, but it can cause ovarian tissue damage. So we have to inform the fertility specialist. Got the point?
Yes, ma'am. Yes, ma'am.
Okay. It was a bit confusing scenario when it came in the exam. But you have to discuss all the options available for her. We are going to do surgery, but with the surgery, these problems can happen. And then what is the solution for that? We have to refer you to the fertility specialist for the egg preservation. That is one solution for her. All right. Next.
I'll do.
Very faint voice.
Anita, ma'am.
Yes, Anita, right. Just raise your voice, huh? Okay.
Sure.
Yes, yes. Come, please. Take you 2 minutes. You all should have a paper and a pencil. Even if you know the scenario, please write down the important points: patient's name, age, BMI, what is your task in 10 minutes, and the domains which you will be tested. Okay.
And next page.
Yeah.
Yes, ma'am.
You want to start? Okay, start, please.
Yeah, ma'am. I want to start.
Fine. Start, please.
Hello, I'm Dr. Anita. I'm one of the doctor in the gynae clinic. May I confirm my name and age?
Yes, I'm Peggy Morrison. I'm 32 years old.
So, can I how may I call you?
Call me Peggy.
Okay. Peggy, I'm aware your GP has referred you with certain investigation report, and you are about to discuss about it, right?
Yes.
So, Peggy, today I'll be discussing all about your concerns, and also we'll carry on forward with the investigation management, what needs to be done, and also later on I'll provide you with the patient information leaflet at the end, and also write back to your GP whatever we have discussed. Is it okay for you?
Yes. All right.
Okay. So, Peggy, may I know more about your concern?
Yes, actually, I'm not having periods for the last 6 months. And, me and my partner are also planning to have a baby. So I'm hopeful that maybe I'll be pregnant. And GP did some tests, and he was a bit concerned about the test results, although he did not discuss anything with me.
So, is it okay if I ask you a few questions first, or you want to discuss with the report first?
Can I discuss the report first? I hope I'm pregnant because I really want to have a baby.
Okay, I see. So Peggy, I have your reports with me, and like the GP has done few tests for you, which are the hormones, where I can see the test has been repeated 2 times. Okay.
Yeah.
These hormones, which is FSH and LH, they are the hormones which releases from the brain. They are on the high. What I can say is like it's on the higher side. So,
Mm-hmm.
Vicky, are you with someone, with your partner right now?
No, it's okay. I don't want my partner to know about my result right now. You can tell me.
Okay, I can tell you. Okay, so Peggy, actually, I don't have a very good news for you. And the thing, seeing the report, what I have, the concern I have is the probably ovaries are not functioning. See, what happens is generally our brain releases some signals which are sent to the ovaries, and in response to those signals, the ovary releases egg as well as some hormones like the estrogen, which is necessary for our general well-being and also for our cycles. Okay.
Mm-hmm.
But in your case, these hormones, what I can see, the FSH, which is the signal hormone, is done twice. They are both high, and also this what it means is that your ovaries are not responding. And in this condition, when the ovaries does not release this hormone, and you are below 40 years, we call such condition as premature ovarian insufficiency.
Okay.
Am I clear to you?
Okay.
Okay. We also have another hormone like prolactin, which is a normal hormone. And also a scan has been done, which where it says both the ovaries are normal, the womb is also normal, and also the inner lining of the womb is normal. And he has also done a pregnancy test for you, which is also negative. Considering this, Peggy, and your concern, can I ask you questions before that?
Oh my God, I'm not pregnant. My pregnancy test is negative.
Yes, yes,
Oh,
Vijay. I'm sorry to convey to you this message, but I'll be definitely discussing about all your concerns and tell you about what can be done further. Can I ask you a few questions prior to that?
yes. All right.
Okay. So can you tell me, apart from what I can see, hot flushes, are you having any night sweats? Any
Yes, I
any
have. I
changes
have
in?
very bad hot flushes
Okay.
and these night sweats as well.
And what about any changes in mood?
Yes.
Any pain and aches in the body?
No, not so much.
Okay. So Peggy, what about your sexual life, if you don't mind me asking?
Okay, so yes, me and my partner are like comfortable with each other, having sex regularly.
Okay. Any problem you face, like any kind of dryness down there while having sex?
Then yes.
Okay. And any time you or your partner had any sexually shared infection?
No,
Okay. How about what about your water works? Any
uh,
difficulty with that?
no,
Bowel?
no.
Okay. And any other like medications you're having?
Like, no, I did not take any medication, just folic acid.
Just folic acid. Okay.
Yeah,
And any medical condition like raised blood sugars or
no,
no? Okay. Any significant concerns like running in your family, especially like any genetic conditions or like any history of cancers or running in the family?
no.
No. Okay. Have you done any surgeries, especially concerning your ovary?
No, not at all.
Okay. Any personal history of clots, and don't mind me saying cancers?
No,
Okay. What about any time anywhere you had received any kind of chemotherapy or radiotherapy for any reason?
no.
And how about your partner, Peggy? How is he? Is he fit and well?
Yes,
Okay. And the if you don't mind me asking, anytime you or your partner do smoke?
no, we have both quit smoking.
I really appreciate both of you for that. And what about any alcohol?
Yes, we take occasionally.
Okay, so actually, Peggy, we don't have any safe limits for alcohol. It's always better to quit alcohol, okay?
Yeah,
Okay. What about any recreational drug?
no.
How about your partner's height weight ratio?
Uh, Same like me, 24, 25.
Okay. Anytime you or your partner had any child previously?
No.
Okay. Thank you so much for the information. Peggy, as far as I can see, what concerns you have is like you are having these symptoms of hot flushes, which generally happens because the ovaries are not functioning and the hormones estrogen is not getting released, right?
Yes.
And the second concern which you're having is like you want to conceive. So coming to the first option,
Yeah.
Peggy, for your symptoms, we do have some hormone replacement therapies. Okay. These are generally given in the form of two hormones. Like we generally give you in sequential means every time you're taking the hormones and at the end of the month you bleed. Am I
Okay.
clear?
Yeah, yeah.
They may be given in the form of tablet, patches, or gels. And these
Mhm.
hormones are very important for the general well-being in the sense they maintain your healthy bone, brain, and also the heart.
Okay.
But we have certain concerns when we give the hormone therapy, like it has some few side effects, like you may have nausea, vomiting, bloated nose, and also like some serious effect like uh, clots, increased risk of cancers of the breast and the womb. But in your case, because you are below 32 years, below 40, generally the chances of breast cancers are very few and it is mostly useful. Okay,
Mm-hmm. Yes.
am I clear?
Yes.
Okay. So, and giving these hormones, we have to repeatedly follow you up. Your first follow-up will be around about 3 months, and to see for if you're having any kind of bleeding or any other symptoms. And then if everything goes well, we'll be repeatedly following you up annually. Okay.
Right. Yes.
And as you told me, you are having some dryness down there. We can also provide you with some local uh, estrogen creams for application.
Okay.
Now, coming to your concerns regarding the fertility, uh, as the eggs are not releasing, so we have for you some options like the options of you can either borrow, we can refer you to the fertility centers, and from there we can have a discussion regarding egg donation. Have you heard about it?
No, yeah, I have heard about it. So how will I get these eggs?
Yeah, generally, what we do is we will refer you to the fertility centers
Yeah.
where they have banks for for egg banks where you
Mhm.
can get the eggs, donor eggs, and then what we do is it will be fertilized with fertilized with your partner's semen, and then the embryo which will be formed will be transferred to your womb. That what process we can call is a test tube baby.
Okay.
Okay, and another option which is always is like adoption, which is a very good option to give someone a good life and a good support. Okay.
Mm-hmm.
Okay.
Okay. Time
So
is up. Yes.
okay. So yeah. And apart from that, to manage these symptoms, we also have a few other lifestyle modifications like stop not to have alcohol and some
Mhm.
practice some general exercises and exercises, relaxing therapy, keeping yourself healthy and yoga, and also some we'll be giving you some calcium and vitamin D. Okay.
Yes. Okay.
Any other concern?
No, no, no.
Okay. Thank you so much.
Your voice is very low.
This is okay. I'm sorry.
Okay. No, the station was okay. I could hear you properly, but still it was little low than before. Okay.
Uh,
But very clear. You speak very clearly. Very nice. Both of you, Shweta, Anita, all of you, you speak very clearly. Very eloquent speech. Very nice, clear words. Okay. So good one. Very good one. Few things which this is not just for Anita, for everyone. When you see any scenario, so just to save your time, if you have a lot of informations given here, just see she's otherwise fit and well. She did not have any surgery, did not receive any chemotherapy and radiotherapy. So just ask in few seconds it will take that I can see you are medically fit and well. Fine. And I can see from the GP note you did not have any surgery and you did not receive anti-cancer medication and radiotherapy. Am I right? Finish it in few seconds. You don't have to ask, are you following GP for any medical condition like diabetes, high blood pressure? Even when you save the seconds, it becomes very important. Okay, so when you're talking about lifestyle modifications, the bell rang. Okay, but just try to save you time if a lot of information is given in the exam. In the exam, actually, there is not just 2 papers. There will be 4 or 5 papers. Maybe in just one paper, they will be having long history. Another paper, they will be having the examination findings, general condition good, blood pressure and this and that is okay, abdominal examination soft and tender. And in another paper, you will be having the investigations results. Another one, there can be ultrasound scan. So yes, you have to scan everything very quickly in the exam. Good one, otherwise, well done. Okay. So, all right.
Just a minute, ma'am. Ma'am,
Yes,
suppose like for PI, we have to rule out thyroid and all. And if we
yes.
ask the patient and if she says she doesn't have any symptoms, then also we need to do the test.
No, no, no. Then no need to do the test. No need. I was coming to that also question because you have to ask cold or hot intolerance. Why? Because it is not given in the blood test. If it was given, prolactin is normal. So you don't have to ask about headache, nipple discharge. But TSH is not given. So yes, fill in the blanks, right? Now that is your part which you have to do. Okay. All right. Hello, I am Dr. Anita, one of the doctors in the gynecology clinic today. May I confirm your name and age, please? How may I address you? Thank you, Peggy. I understand that you have been referred by your GP as you're having hot flushes and no periods for 6 months. And GP ordered some blood test and scan, and you are here, or I am here to discuss the test results. Am I right? Is there any other concern and expectation from today's meeting? She will be very much concerned. So I want to discuss about my result first, doctor. Yes, I can see how much concerned you are about your result. And I have the test results right in front of me. And GP has done all that test and he has included your test results in his letter because it is all included in the GP letter. It is not given separately like name, date of birth, NHS number. All right, but here, like if it is given on top, yes, of course, you can say that I have in the GP letter, I have your test results and I have confirmed your name, date of birth, NHS number. And like, do you have any idea about the result? So breaking bad news in 2 steps. It is something very serious which you are going to convey to her. I have serious concerns regarding your result. I'm afraid I don't have good news for you. The blood test was done to check for the 2 hormones which are secreted from the brain. These are the female hormones, FSH and LH, and they tell how the ovaries are functioning. And when ovaries are functioning normally, they are within normal limits. They are increased when ovaries are not functioning normally, and in your case, they're increased. It means that ovaries are not functioning normally. And I have concern about the scan also because the ovaries are small. Ovaries were not normal. It was already written in the scan that both your ovaries are small and no eggs were seen. The milk hormone is normal. And I'm sorry to say that the pregnancy test is negative. She repeatedly wanted to know whether she is pregnant. So when you're discussing about the pregnancy test, you have to take some caution that I'm sorry to say, signpost her because she wanted to hear the news that she is pregnant. She kept on telling you that I want to have a baby, doctor, and I hope my pregnancy test is positive. Say she had so much of hope. So signpost. And I'm sorry to say, Peggy, that your pregnancy test is negative. And we call this condition as premature ovarian insufficiency. Have you heard about it? Doctor, what are you talking about? I'm not pregnant. My God, I did not have periods for the last 6 months. Then first address that issue. Yes, she will say, I wanted to have a baby. I'm not pregnant, doctor. Yes, I can see how upset you are. I'm sorry to be the bearer of this difficult news. Would you like to call someone to be with you? Is it okay if I carry on with the consultation? And can I carry on with our discussion? So let me then go back. Let me explain to you what the condition means. It means that ovaries are not working properly. They're not able to produce the hormone estrogen in normal amounts and not producing eggs normally. That is why you're not having periods and having symptoms of menopause like hot flushes. Eggs are not produced normally, so I'm sorry to say that you may not be able to get pregnant. However, come down in this condition, ovaries may release eggs sometimes, and you may get pregnant, but the chances are very low. 5 to 10 in 100 women can get pregnant. Doctor, is there any medication you can give me so that I can get pregnant? I'm sorry to say there is no medication to enhance the chance of natural pregnancy. So the template will be up and down in the exam. It is never a smooth ride. It is always a bumpy ride in the exam. Okay. So in order to plan your care, I would like to ask you a few questions and then discuss the management plan. Will that be okay? I will also give you the written information leaflet and write back to the GP about our mutually agreed care plan. Can you tell me more about your condition? I can see that you're having hot flushes, any other symptoms, like night sweats. Very nicely, you asked about mood changes, any irritability. So you will add on those symptoms. Well done. Any cold or heat intolerance, any change in the weight? Is it affecting your quality of life? How are you coping? When was the last periods? I can say it was 6 months ago. And how were your periods before that? Are you updated with the cervical screening? I would like to ask you some personal questions. Now, here, yes, your sentence will change because she already told you that me and my partner are planning for a baby. So it means that she's already with someone. So no need to ask, are you sexually active and this and that? Yes, I would like to ask you some personal questions. Do you have any problem during sex, like vaginal dryness? Have you been any birth control method before? Okay. And ops history, have you ever been pregnant before or your partner has fathered any child? I can see from the GP letter that you're medically fit and well. And few questions you can ask. Okay, any history of clots, or I would like to know any history of cancer of breast or womb. And are you taking any medication? Okay, only for folic acid. Any allergy? I can also see that you did not have any anti-cancer therapy or radiotherapy, and also no surgeries. Am I right? Any family history of concern? Anyone in the family with similar condition or early menopause? Any history of blood clots? Pardon me to ask, any cancer of the ovary, womb, or bowel? I would like to know whether you or your partner smoke cigarettes or drink alcohol. And pardon me to ask, any recreational drugs. So yes, smoking and alcohol they don't have any health benefits. So we would like to put you in touch with ours. Stop smoking and stop alcohol services. Will that be okay? May I know what you do for a living? Whom are you living with? Is your partner supportive? Is he fit and well? May I know his BMI? Okay, smoking, you have asked about both of them, so no need to repeat again. Have you been feeling low down? Yes, I'm very much low, feeling low now after hearing all the reports and everything. So, do you need any help regarding that? If so, we can put you in touch with our counselors. Thanks for these informations. Would you like to add anything important? Yes. Now, I just forgot one thing also, that you also have to offer her some tests just to rule out any cause of her condition, because like we have to offer you some tests to find out the possible cause of your condition. Like most of the time, in 9 in 10 women, no cause is found, but sometime it can happen because of high blood sugar, although you're not having any sugar and like thyroid. So we have to check for the thyroid test. And if no symptoms of thyroid, you're not going to check. Genetic makeup and check the bone scan to assess your bone strength. This one is required because she's not having periods for 6 months. FSH is very high. So we have to assess the effect of hypoestrogenism on the bone. Okay, so this one is the DEXA. We have to check the bone mineral density. We are going to do this one. All right, so then coming to the management, like you divided into two, that yes, as you have concerns regarding having a baby, so I would like to tell you there is still hope and options are available. So is it okay if I discuss them with you? One is the egg donation and other one is the adoption. Would you like to know more about the egg donation? So she will ask, how am I going to get these eggs? So you can get these eggs by 3 means. One is from someone known to you, and you can find them even in the internet. Other one is through the egg banks, and one is reproductive tourism, where you can travel to some other country to get the egg. Now, egg banks, they are licensed in the UK, but the waiting time is quite long. And if you get the eggs, then the donor eggs are mixed with the partner's semen in the lab, and resulting embryo will be placed inside your womb. And you can opt for adoption. Like you said, very nice lines that there are some children who need to be adopted by beautiful parents like you. And we can refer you to the fertility specialist who will talk about all these options. Now, why I talked about the egg donation, please know this in the detail: egg donation, sperm donation. There was a scenario which came in last exam. She was a single mother. She wanted to know about the sperm donation. So I have a YouTube video, Single Parenthood and Sperm Donors. Now, if you have a scenario like this, scenario can go in the direction of egg donation. Maybe she would like to know everything about the egg donation. So instead of the sperm donor, change that word to egg donor. All the medical legal issues, everything is same like the sperm donor. Okay. So I will share that YouTube today in the group. Go through that. All right. Now, you will address about the menopausal symptoms, that you are having hot flushes, night sweat, mood swings. So, and there is risk of brittle bones and heart problems because of the lack of the female hormones. So we can offer you hormone replacement therapy. It contains the hormones which your ovaries have stopped producing. It is available in many forms like tablets, patch, and gel. And when you will start the hormone therapy, you will have monthly bleeds like periods. You will continue it till the natural age of menopause, 15 years. Okay, what are the benefits? It will improve your symptoms, but there can be some risk: nausea, vomiting, indigestion, and clots, which is less with the patch and gel form. Any treatment, medical, surgical, whatever, always discuss the risk and complication. That is the patient safety. It has got an asterisk. If you will talk everything about the HRT and you are not going to discuss about the risk, the patient safety will be compromised. There is no increased risk of breast cancer when taken before the natural age of menopause. She asked in the exam, doctor, there is risk of breast cancer. I heard with the HRT, no risk when taken before the natural age of menopause. What about the follow-up? Yes, after 3 months. If everything is okay, then annually. For the vaginal dryness, local estrogen cream, and also you can use lot of lubricants and vaginal moisturizer. Fine. Lifestyle modification, yes, we would also like to give you some advices like you can have calcium and vitamin D supplements for your bone health. And you can also enroll in some exercise program. Stopping smoking and cutting down alcohol will also help to improve your condition. Any questions? Okay. Then, okay, in her case, yes, I will inform my consultant, refer you to the fertility specialist, and arrange appointment with the menopause clinic also, because PUI and all these, we have to refer them to the menopause clinic. Give the support group numbers, like you can remember a few of them: Daisy Network, Premature Menopause Support, Premature Ovarian Failure Support Group. Contact numbers for clinical access. Now, if there is a scenario where the patient, her family is complete, she's only having menopausal symptoms and she's no fertility issue, so she wants treatment, then here you are going to discuss about the HRT versus COCP, the pros and cons, and the contraindications to both of them, and what can be their side effects. You will discuss that. Now, she is refusing HRT, then of course, then you can offer the COCP. But what the talk says that HRT is more effective in treating hot flushes and night sweats as compared to the COCP. So if this lady wants only COCP and she doesn't want to have children, so we know that still in 5 to 10 in 100 women, there is chance that egg can be released and she can get pregnant. So the talk says, give her one more option. She can use condom with this COCP. because this COCP may not be able to suppress such high levels of FSH in POI. If she is taking HRT and she doesn't want to have a baby, you have to tell that HRT is not a contraception. With this, we will offer you some contraceptions like some devices which can be inserted inside your womb, hormone releasing device, Mirena, or the copper releasing device, and condoms. Okay, then pros and cons of, and which one would you like to prefer? Okay, with the condom, STI risk will be less. Talk says HRT and COCP should not be given together. And as per the talk, the best contraception in POI is IUCD and condom. So if she is only going for the HRT, then we can give her the Mirena as well. Any contraception has to be given to this patient. With HRT, we are not going to give COCP because COCP should not be given together. This is what has been mentioned in the talk, Mirena, IUCD, or condom. Okay. And anyway, until now, the scenario which came in the exam was related to the subfertility. And there is a new talk on POI, so this is also a hot topic. Yes. Okay. Let's move. Next one. Who would like to come forward? We have done this one. Okay. I need a volunteer. Not volunteer.
Yes, I want to. Yes, I want to.
Bushra.
Yes.
Today on duty or at home?
No, I am at home.
All right. Take you 2 minutes. 1 minute. Just one slide, okay? Every one of you should have a paper and pencil. Please note down the important points in the scenario.
Yes, doctor, I can start now.
Fine. Start, please.
Hello, I am Dr. Bushra, covering emergency department today. Am I talking to the Kate William, 33 years old?
Yes.
Okay, can I call you Kate?
Yes.
Kate, I can see you have a pain and vomiting. Can I ask my nurse to give you pain relief medication and medication to relieve vomiting? It is
Yes.
okay?
Yes, because I feel like throwing up again, and there is also so much of tummy pain. I need those medications.
I am so sorry, Kate. You have a difficult time. But do you have any drug allergy?
No allergies.
Okay, Kate. Let me know when you feel comfortable to continue consultation.
Okay, yeah, you can carry on.
Okay, Kate. I can understand from your clinical notes you have underwent first IVF cycle and ovum have been picked up, and after that you have tummy pain. Am I right?
Yes.
Okay, Kate, I want to ask some question and then we will make a management plan that will be mutually agreed and safe for you. Before that, can you explain me more about your condition?
Okay,
pain?
yes. Mhm.
Okay. Since how long do you have this pain? When it is started?
Yeah, it is for the last 3 days, but today it became so severe that I came to the emergency department.
Okay, and can you score the pain from 0 to 10? 0 means no pain and 10 means severe pain.
It is about 7 to 8.
Okay, and what is the nature of the pain? It is dull, aching, or colicky pain and sharp.
I can't differentiate that, but it is all over in my lower tummy on both sides.
Okay, and do you have any medication at home to relieve the pain?
I just took paracetamol, but my pain was not relieved.
Okay, and since how long do you have vomiting?
For the last 3 days.
Okay, and can you do you able to hold any fluid and food down?
No, not at all.
Okay, do you have any shortness of breath and chest pain?
No.
Okay, and do you notice your tummy size increasing?
Yes, my pants are getting tighter.
Okay, and do you have any pain and swelling in the legs and down below area?
No.
Okay, okay. Kate, can you inform me more about your IVF cycle? May I know the reason why you have gone through this IVF procedure?
Yes, because me and my partner, we were trying to have a baby, and I already have been diagnosed with condition of the ovary, and that is they told it is PCOS. I took a lot of medications. I could not conceive, and then I was given these injections, so that I can conceive. And after the injections, my condition became horrible.
And I can see from your notes, the eggs has been picked up 3 days back. Am I right?
Yes.
And have they transferred the embryo or not?
No, I don't think so.
Okay. Okay, Kate. Can you tell me, do you have any condition for which you are visiting your GPA, high blood sugar, high blood pressure, blood clot formation in the legs?
No.
Any family history of concern in the family? Any person have PCO like you?
Yes, my sister has.
Okay. And do you have any surgeries in the
No.
tummy and down below?
No.
Okay. And to double confirm, I know you had no drug allergy. Am I right?
Yes.
Okay. I have been provided with your weight to height ratio, and it is normal 24. And your blood group is A positive. Am I right?
Yes.
Okay. Okay, Kate. Currently, are you using any medication?
No, just folic acid.
Okay. Okay, Kate. Some personal question. Do you smoke, drink alcohol?
No.
Any recreational drugs?
No.
Okay. And how do you feel from last 1 month? Any low mood and depressed?
No, in fact, I was happy that now I'm going to have a baby, but because of this condition, I'm not feeling okay at all.
Okay. Okay, Kate. Do you have any other concern to discuss? Any question to add?
No, I just want to know what's happening to me. And can I have a baby?
Okay, Kate, definitely. I will address all your concern. Before that, I want to examine you in the presence of Chepron about your general condition and examination of your tummy to see any fluid in the tummy and down below, and examination of your legs, any swelling. Is it okay?
Yeah.
Okay, thank you for cooperation, Kate. Kate, your investigation and ultrasound report is with me, and I confirm your name and address number. These reports belong to you. Do you want anyone beside you before discussing the reports?
No, it's okay. You can carry on.
Okay, Kate, your blood investigation are showing your blood is concentrated than normal, and ultrasound report is showing the ovaries are enlarged and having fluid-filled sac. And in medical terminology, we are called ovarian hyperstimulation syndrome. Have you heard about that?
No. Yes, actually, my fertility specialist told me, but is it happening to me?
Yes, Kate, let me explain. Some women, if they receive the drugs that stimulate the ovaries to form the eggs and releasing the eggs after the injection, sometimes the ovaries become enlarged and become the fluid-filled spaces, and they release the chemicals into the blood. And this chemical cause the escape of the fluid from the blood vessels into the tummy, around the heart, and in the lungs. So the woman may have a tummy pain and shortness of breath Am I clear so far?
Yes.
And Kate, if we will not treat at time, it can be a life-threatening condition because the blood has been concentrated, so there is a risk of blood clot formation in the legs and lungs. Am I clear so far?
Yes, yes.
Okay, Kate. So there are three types of ovarian hyperstimulation syndrome, and from your investigation, I can understand you have moderate ovarian hyperstimulation syndrome. So I would like to admit you in the hospital. Is it okay with you?
Admission, well, no, actually, I just want to go home after a few hours because me and my partner, we are going to celebrate our anniversary tomorrow.
Okay, Kate, congratulations for your anniversary. But I would like to ask you, can you come for follow-up after 2 to 3 days?
Okay, that would be fine. Yeah.
Okay, then I would like to suggest some blood investigation, like liver function test and renal function test, and my consultant in a while will chat with you. And after that, you can go home, but I will discuss with you all the management plan and also the follow-up. Okay.
Yes.
Kate, first of all, you have to drink the water according to the thirst, and also you have to monitor your pee, how much amount of urine are you passing, and what is the color of the urine. And for your pain relief we will give you the pain relief medication like paracetamol and codeine, and we will avoid the anti-inflammatory drugs because they are affecting the kidneys. Okay, and also we will give you the anti-sickness drugs to relieve the vomiting. And as you have a plan to go home, so we will advise you to wear the leg stocking to prevent the blood clot formation in the legs.
Okay.
Are you following me?
Yes.
Okay, Kate, and you will come after 2 to 3, every 2 weeks, you will come for the follow-up in the clinic, and every visit we will monitor your general condition, pulse, blood pressure, temperature, and also your waist size to see any buildup of the fluid in the tummy or not. Are you following me, Kate?
Yes.
But Kate, I would like to inform you if there is you have a severe pain in the tummy, and we are considering there is a build-up the fluid in the tummy, and you have shortness of breath, and you're not passing the urine in adequate amount. Maybe we have to remove the fluid from the tummy and under the ultrasound guidance, and this is called paracentesis. Is this okay?
Yeah.
And I would like to advise you for general advices. We advise you to avoid the sex and heavy exercise because the of these are enlarged and they can twist around its own.
Okay,
Okay.
I have a question. Yes, can I have a baby?
Yes, Kate, regarding your this cycle, I am sorry to inform you, we have to cancel this IVF cycle because if you get pregnant, then in this case, the condition can worsen. Okay, and even if you get pregnant with this condition, the pregnancy will be high risk. There is the increased chances of blood pressure and passing protein in the urine, and baby can born before 37 weeks of the pregnancy. So we will like to yes, and we for that we will also inform the IVF team. They will discuss with you. And Kate, one important thing, I will write the incident report, and we will see the matter. And when the result will come, I will discuss with you with the honesty. It is okay?
Right. Okay. Fine.
And I will provide you the patient information leaflet, and I will inform my consultant. He will do some chat with you, and we will plan for your follow-up visit.
Fine.
Okay?
Thank you.
Do you have any question?
No. Thank you.
Thank you.
Okay. Everything was okay. I'll tell you just few things so that you can improve more in the exam. The important question which I asked as you were running off the time, so I asked about the embryo transfer because that thing you tried to say in the beginning itself, after explaining the OHSS, tell to both the things that no embryo transfer because of your condition. I'm sorry to say about that, and incident reporting. although it is a moderate one, but this RCOG guideline on the clinical governance, good practice, or there is a SIP also. They have mentioned about the incident report. They have a nice table in that, and they have mentioned. So when you are explaining the condition, any complicated condition where you have to write the incident report, mention it then and there, so that you are not going to forget in the exam. Okay, and embryo transfer is something very important. So tell about the embryo transfer then and there. Alcohol, recreational drugs, no need to ask in this. Smoking also, it was not required. If you have asked smoking, you can just say, I'm concerned about your health, because any patient who is going for IVF, it is taken for granted that they won't be smoking. If they're smoking, they won't be having the IVF cycle. Okay, fine. And your
Sorry.
offered me the medications. Yes, Pushra?
Sorry, doctor, then we will write incident report now, because clinical governance written,
Yes.
we will write moderate incident report.
You have to
And
write.
for severe and critical, we will inform also HIFA.
Yes, exactly. Within 24 hours, we have to inform the HIFA. Yeah, exactly.
Thank you.
Okay, welcome. So you are in the emergency department. Hello, I'm Dr. Bushra, one of the doctor in the emergency today. May I confirm your name and age, please? Is it okay if I call you Kate? I can see that you're having pain in your tummy and you're throwing up. How are you feeling now? Can I ask my nurse to give you some medications just to confirm, do you have any allergy? Let me know once you feel better. Can I carry on with the consultation now? I would like to ask you a few questions to know more about your condition. May need to examine you and arrange some tests and then discuss the management plan. Will that be okay? I shall also give the written information leaflet about your condition. Is there any other concern in particular which you want me to address today? All right. So can you tell me more about your condition, about the pain? What about the severity of pain on a pain scale of 1 to 10, where 1 is mild pain and 10 is severe pain? And can you tell me, since when are you having vomiting? Is there anything which relieves it? Anything which worsens it? Are you able to keep the fluid of food down? Sorry to see you in this condition. We are here to help you. I would like to ask you a few more questions. Is it okay? Do you have any chest pain or difficulty in breathing? How about your waterworks? Have you noticed any change in color of urine? Any weight gain? Have you noticed your pants becoming tighter? Any leg pain or swelling? These are very, very important questions. So how not to forget all the questions in the exam? Go from top to bottom. So what is the top point? Pain. Okay, pain is a presenting complaint. Fine. What comes up? Mouth is there, isn't it? I mean, just to make your life easy, I'm explaining it in a childish manner. Vomiting is from your mouth. After the mouth, what is there? You have your chest. Just keep your hands on your chest. You will not forget in the exam. After the chest, what you have? The bladder, waterworks. Weight gain, the waist. Okay, have your pants getting tighter. After that, what comes? Your leg comes, isn't it? So you're not going to forget your mouth, your chest, your bladder, and your legs. Okay, leg pain or swelling. And just ask a little bit about the IVF procedure. I can see that you had the IVF procedure. May I know why? Can you tell me in your own words what happened exactly? Yes, diagnosed with PCOS, she will tell all that. I can see 18 eggs were removed and any embryo transplant was done. Are you following GP for any other medical condition? Are you on any medication, any allergy, any surgery on your tummy or down below? And may I know about your partner and support? No need of smoking, alcohol, recreational drugs, family history, skip, because it's not going to change your management plan, isn't it? Partner and support, and she's in the emergency. Keep your history very focused. Otherwise, you will be wasting time. It is not that they're going to deduct your marks. You will waste your time because you have to explain a lot of things. Have you been feeling low down? Yes. So we can also put you in touch with the counselors. Will that be okay? Thanks for these informations. Would you like to add anything important? I would like to examine you with your permission and in the presence of chaperone to assess your general condition and to see how much fluid you have lost and legs for any swelling or pain. Will that be all right? Thanks for the examination. I have your test results also, and I have confirmed your name, date of birth, and NHS number. Do you have any idea about the result? I have some concerns regarding your result. Warning shot you have to give in her case. Some concerns. What is the concern? The blood test was done and it is showing that blood is more concentrated than usual because hematocrit is high. Ultrasound scan is showing that ovaries are quite large in size and there are many fluid-filled spaces in the ovary. And from the informations which I have gathered and from the test results, most likely you are having a condition known as ovarian hyperstimulation syndrome. Have you heard about it? Yes, many of these patients, they know about it. I just ask her, did your fertility specialist inform you about it? Yes, you're right. And so may I know what you know about the condition? She will tell you something. Yes, you're right. Would you like me to explain a little bit more about the condition? It can happen as a complication of IVF and fertility treatment. It happens when ovaries over-respond to the injections and medications given during the cycle. They release more eggs. They become bigger in size, and this causes tummy pain. There is also leakage of the fluid from blood vessels, which gets built up in the tummy, lungs, and heart, and this can cause difficulty in breathing. Am I clear so far? So here itself, you can talk about writing the, so it is a serious condition and we are going to write an incident report to see why this has happened. And once the report is available, we are going to discuss that with you. Will that be okay? Fine. Now, regarding the management, we can offer you medications to relieve your symptoms. And I would like to tell you that there are not 3 types, Bushra. There are 4 types of OHSS: mild, moderate, severe, and critical, isn't it?
Yes, I know.
Yes.
But I forget.
But it
No,
was maybe
everyone.
a slip
Yes.
of the tongue. Okay.
Yes, yes.
Yes, there are 4 types of OHSS. If you want to explain that way, use your language. You're free to use that. There are 4 types of OHSS, and depending upon the you can say depending upon the severity, the OHSS is classified into 4 types, and you are having the moderate type. Okay, but still it can progress to the severe or the critical type. So we would like to offer you admission and so that we can arrange some more tests for you. Is it okay? Just wait for her response in any station when you are talking about admission. So are you okay with the admission? No, doctor, I don't want admission. I have an anniversary tomorrow. Yes, congratulations on your anniversary. So will it be okay that you wait until the test results are available? I will also be informing my consultant so that he can have a word with you. There are few more blood tests which needs to be done, like we have to see how your liver and kidney are working and how the blood is clotting. I will just go back. You have to see in the exam what is missing. Blood test. They just did the full blood count, hematocrit, no LFT, no KFT coagulation profile, which has to be done routinely. Okay. So whatever is missing, you're going to offer that. Embryos, and I would like to tell you, and I'm sorry to say that embryos will not be transferred. The cycle needs to be cancelled and embryos will be frozen. Why? Because if embryos are transferred now and you get pregnant, then the condition can worsen. Once your condition improves, embryos can be transferred in the next cycle, and this will be discussed by the fertility specialist. Any questions? So regarding your management, if you go home, we will be offering you simple painkillers like paracetamol or codeine. Avoid aspirin or aspirin-like medications. They can affect your kidney. We will be offering you the anti-sickness medication. Try to drink to thirst to avoid any fluid overload and offer leg stockings to prevent the blood clots. But if you're ready for admission in that case, we will offer you the blood thinning agents. Now, regarding the follow-up, it is very important to come to the clinic every 2 days. So will you be able to come to the clinic for the follow-up? Just ask her to reconfirm. Yes. Why it is important? Because nurse will check your blood pressure, temperature, pulse, breathing rate, and the waist size to see if there is any fluid buildup or not, and whether your condition is improving or not. And also, when you go home, you have to take some precautions, see how many times you pass urine, how's the color of the urine. Avoid any strenuous exercise and sex because ovaries are big. They can get twisted anytime, and this can cause severe pain, and try to mobilize and be active. Any questions? Talk about the warning sign that if you have any tummy pain, leg pain, swelling, difficulty in breathing, chest pain, difficulty in passing urine, please report to us immediately. And for that, we are going to give you the 24/7 hospital contact number. So As of now, I will also be writing back to the GP about our agreed care plan, inform the fertility specialist. And if you notice any fluid buildup in your tummy and difficulty in breathing, inform us, because in that situation, we may have to offer you a simple procedure to remove the fluid from your tummy. Is that okay? Give the support group number. If you forget the incident report, you can write it here. But idea is that whenever you are discussing about any serious incident, like we will discuss in the surgical module, you have post-surgical complications, explain that complication like pulmonary embolism, and I'm going to write the incident report right away. So you're never going to forget it. Okay, fine. Now, this is just from the Green Top guideline, the history. All right, so time of onset of symptoms and everything we have asked. PCOS syndrome diagnosis is important. And here the role player, she herself told you about this. Symptoms, all the symptoms you have asked, good. Now, examination part is also fine. Everything is okay. Investigations, the routine ones, which we have to do, the simple ones, full blood count, hematocrit, okay, C-reactive protein. Now, what is missing here? Urea and electrolytes, and LFT, KFT, we have to do. Coagulation profile, we have to do. Ultrasound scan was done. Other tests will be done if patient is complaining of breathlessness, leg pain and all. These are not done routinely. Okay, so just try. We are going to do these tests routinely. Now, just a quick revision. Where is our patient? This was here, isn't it? Hematocrit was less than 0.45. That is why our patient came in the moderate OHSS group. She had nausea and vomiting, ultrasound evidence of, no, it was not ascites. Ovarian size was big, and nausea and vomiting. If there is nausea and vomiting, it will be moderate OHSS. All right. Until now in the exam, the scenario has always come as moderate OHSS, 0.42 or 43 hematocrit, and with nausea and vomiting. So confusion was whether we will offer admission. So just remember, it is a combination of two guidelines. And not two guidelines, like even in the Green Top guideline, the bold points they have mentioned when we are going to admit the patient. One is clinically, also if the patient is not able to take the fluid and food, and she is very dehydrated, and in that case, we have to offer admission to the patient. That is the thing. Because moderate OHSS, usually we don't, even in some cases of severe, we don't offer admission routinely. But if patient is not able to keep the fluid and food down, we have to offer admission. So it is your applied clinical knowledge. That is the thing. Okay, thank you.
Excuse me.
Yes.
Doctor, it is written in the guidelines in case of mild, moderate, and some cases of this severe OHS, we will manage the patient as a
Outpatient.
home patient. Yes, outpatient.
Outpatient, exactly. But when you will go further in the guideline, they have mentioned that admission also depends upon the clinical condition of the patient at that moment, whether she's able to keep the fluid or food down or not. How is the patient's general condition at that time? So we have to assess that as well. I will share that screenshot in the group. Okay. So our patient, she was not able to take fluid and food down, and she was throwing up too much. So, and all the blood test was not done. So just even for a few hours, we would like to offer you admission to keep you under observation. Let my consultant come have a chat with you, and only then we can discharge you. All right. Now, still we have 3 stations. Next, someone has to come forward. Dr. Vidya Lakshmi. Are you there today? Vijaya Lakshmi with Dr. Vidya Lakshmi, isn't it? Are you? No, she's not there. Dr. Shanti.
Yes, ma'am.
Yes, all right. Okay, please. Come, please. Have you done structured discussion? I think you have done last time, or not?
Yes, ma'am. Once I have done.
Once you have done, fine. Okay, do this one.
Okay, ma'am.
2 slides. Take you 2 minutes.
Yes, ma'am. Next slide.
Mhm.
Sure.
Yes, ma'am.
You want to start? Okay, start, please.
Hello, I'm Dr. Shanti, one of the doctor in the gynec clinic today. Can I check your name and age, please?
Yes, I'm David Morrison, 36 years old.
I came to see from your case notes that today you are here to discuss about your semen result and it has been repeated. Is that right?
Yes.
So, can you tell me in your own words, how can I help you today?
Well, actually, I'm a bit concerned about my results. So, can you discuss that? I hope now the count have come as normal.
Yes, Davidson. Yes, David. I have checked your name as well as NHS number, and that outset, I want to say that everything we discuss will be top confidential. No one will come to assess about our discussion. Is that okay?
Yes.
I have some concerning news today. The second sample. Do you know anything about your results before?
Oh, yes, yes. I was told that the sperm count was less. Yes, I know that.
Yeah, the second sample we have checked also shows the same. The sperm count is less than what we expect to be normal, and the motility of the sperm is also less. The sperms are weak, and the normal forms are also less. I'm very sorry to give you this information. So, do you want to continue with the discussion?
So it has become lesser than before.
Uh, it is previously it was like 7.5. Now it has been 10.5 million. Sorry, the first, I'm sorry. Now, yes, it has been reduced.
My God, so am I going to have a baby or not?
With the sperm count, I'm sorry to say that natural conception is not possible.
Okay.
So regarding the further management plan, before discussing the further management plan, I want to ask you a few questions. Is that okay for you?
Yes, okay.
So, do you have any recent illness like fever or flu?
No,
Any recent change in shaving frequency or a hair growth?
no.
Do you have any history of childhood mumps?
No,
Any other medical condition like diabetes or thyroid disease?
no,
Any allergies?
no.
So, do you take any steroids from outside, like for bodybuilding?
Yes, I'm a gym instructor and you can see my muscles, you can see my biceps. You can see these muscles are so strong. So yes, I'm taking the steroids.
Oh, okay. So do you know what the composition is?
Actually, my friend is a pharmacist, and he told me there is something called testosterone, and it can help me to build these like six packs and all those. So I'm taking that.
Okay, fine, David. So I want to look into it, what you are taking, the composition and everything. Is that okay?
Right, yeah.
So do you have regarding the your sexual life? So can I ask few personal questions?
Yes.
So how about your sexual life? Do you feel any difficulty, or how often you join with your wife?
Well, no difficulty. We are having sex about 2 to 3 times per week.
Okay. So any difficulty in ejection or ejaculation?
No,
So do you have any other like sexually shared infection in the past?
no.
Okay, fine. Um, do you have any family history of concern, like any genetic disorders land in the family?
No.
Okay. Few personal questions. Apart from the steroids, do you smoke?
Yes, I do.
Um, David, I want to inform you that smoking will decrease the sperm count.
Mm.
So, have you ever thought about quitting smoking?
Okay, if it will help, I will do that.
That's fine. Then I will put in touch with NHS Stop Smoking Services. Is that okay for you?
Oh, yeah, that's okay.
Yeah. So, apart from that, do you drink alcohol?
Occasionally, yes.
Any IV drug abuse?
No.
Okay. Well, alcohol will also decrease the sperm count. So I advise you to quit alcohol as well.
Okay.
So you said you are a gym instructor.
Mm-hmm. Yes.
What about the support usually during taking treatment? So how about the relationship with wife? Is she supportive?
She doesn't know about me taking the steroid. Otherwise, she is very supportive.
Okay, fine. And what about your mood as well as in the past 4 weeks? Have you ever seen any depression or anxiety in your mood?
No, I was just concerned about my result. That's all.
Fine. So your BMI, your height to weight ratio is 24. Is that right?
Yes.
Okay. Thank you for all the informations. Do you want to add anything? Have you ever fathered a kid before?
No.
So thank you for all the information. Do you want to add anything else?
No.
Yeah. So let me explain you. So your condition. So first, your sperm count was 10.5 million. Now the second sample has been showing 7.5 million. Okay. So have you collected after a period of abstinence, like after 3 to 5 days of abstinence?
Yes.
Fine. Okay, fine. So what we tell in medical terminology is oligospermia. Have you heard about it before?
No, I don't know.
So usually the sperm count should be 39 million, but your thing was about 7.5. Okay.
Mm-hmm.
So why this happens is there are due to several reasons. So like sometimes due to infections like mumps in the childhood or genetic disorder in a male, or because of hormonal factors. Like from your history, what I have gathered is you are taking steroids. Okay. The
Yeah.
steroids actually contains, and you say that it contains testosterone. So that is a very good, excellent drug to build up the muscles, and but it has some drawback also. So this testosterone will go and block all the stimulus which comes from the brain. Like certain hormones are very important, which has to be come from the brain. Like certain hormones are important. So these testosterone will go and block those hormones. Okay.
All right. Yes.
So we advise you to stop these steroids, but it is not advisable to stop immediately. We'll put in touch with some specialist called drug specialist, so who will teach you how to stop it like gradually. Okay,
Mm-hmm. Yes.
and these drugs are also very harmful to the heart, kidneys. So we have to make sure that everything is normal for you.
Okay.
So your treatment will be now with by a group of doctors. I will put in touch with fertility specialist, hormone doctor, as well as the andrologist who will look after you. Okay.
Mm-hmm.
And we make sure that after quitting these steroids or slowly stopping these steroids, your sperm count mostly will improve after 3 months. So we have to repeat the sperm count after 3 months.
Okay. Mm-hmm.
And if the sperm count is not improving, then we have to, with this sperm count, definitely the natural conception is not possible. Then in that case, we'll go for the next step, which is called test tube baby. So we will put in touch with fertility specialist. What he will do is they will give some injections for your partner, and then they will extract the eggs from her, and then in the lab they will mix your sperm as well as her eggs and form a baby, and that will be kept inside the well prepared womb of your partner. Okay.
All right.
The advantage is the 30% success rate is there, and the disadvantage is these test tube baby procedure is like it can cause some it can sometimes stimulate your partner's ovary much, and it can cause ovarian stimulation syndrome, and it can also sometimes we need to put two babies inside. In that case, you may end up in multiple pregnancies also. Okay.
Yes, yes.
We have to check with the we have to check whether you are eligible for then eligible for these IVF procedures or not. We will put in touch with the clinical care commission groups who will decide about the whether the funding is eligible for you or not. Okay.
All right. And can you tell me about my wife Lucy's results?
No. Next time you come with your partner, because of confidentiality issues, I cannot discuss her results now. So next time you both come together, then I will be able to discuss that results. Okay.
Right. Yes, yes. Okay.
So with that, if she's then another option is there which is called donor sperm method. So this here what we will put in we will go for licensed fertility centers will be having sperm banks where where we get the sperms, and then that will be put into your partner's womb through a plastic tube that is called IUI procedure. Okay.
Yes.
That will be less complicated than the test tube baby.
Right. Time is up. Okay.
I will give you the patient information leaflet, and I will put in touch with a drug counselor doctor as well as the andrologist, and I will write back to your GP. Okay.
Right. Okay. Thank you.
Yeah. Thank you.
Good one. Okay. From my side, and I don't think I have to add anything. It is a very, very famous recall. So good. You ensured confidentiality as well in the very beginning. That was very good. Okay, fine. So I don't have to add anything extra. All right. So let's discuss the result. Okay. So you are in the Subfertility Clinic, right? Hello, I am Dr. Shanti, one of the doctors in the Subfertility Clinic today. May I confirm your name and age, please? How may I address you? Thank you, David. I understand you can, I have written just one line in the aim, but in the exam, yes, you can make your own sentences. That, David, I can see that you and your wife Lucy are trying to conceive for the last 2 years. Am I right? And you were offered some test and you're here to discuss about your test result. Am I right? Okay, I'm very much concerned about my test result. Doctor, I would like to know about the result first. Yes, I can see that yes, I can see how much worried and concerned you are about your result. So I have your result right in front of me, and I have confirmed your name, age, and NHS number. So this is the second test which was done to assess your semen, isn't it? Are you aware of that? Yes. Okay. So I have some concerns regarding your result. I'm afraid I don't have good news for you. Actually, yes, there were so many things. Yes, Dr. Shanti, I wanted to tell you it is not just about the number. It is about sperms not moving. So it is not just oligospermia. It was oligoasthenoteratozoospermia, isn't it? So
Yes,
instead
ma'am.
of using that term, you can just explain that your test result shows that number of sperms are lower than the previous result. Previously, it was 10.5. Now it is, I'm sorry to say, it has decreased more, 7.5. They're not moving as fast as they should. Motility was less. And there is increased number of abnormal looking sperms. So all three things you have to explain it to him. And I'm sorry to tell you that with this result, it's very unlikely to have a natural pregnancy. Oh my God, doctor, I can't have a baby of my own. There is a still hope and there are options available. So in a moment, is it okay if I discuss with you about those options? And before that, is it okay if I ask you a few questions to know more about your condition? Okay, then go back to the information gathering. And is there any other concern and expectation from today's meeting? So can you, I can see that you have come alone, and may I know your partner didn't come with you today? May I know why? Okay, she's busy. And may I know, okay, why you had the test done? It is finished now, so you and your partner, I can see that you and your partner were are trying for a baby for 2 years, isn't it? And may I know, have you fathered any child or your wife had a child before? Have you taken any treatment for that? I would like to ask you some personal questions. Uh, are you having regular intercourse with your wife? May I know how many times a week? Any problem during sex like arousal, erection, ejaculation? Any history of sexually shared infection in you or your wife? And regarding medical conditions, are you following GP for medical condition like diabetes, high blood pressure? Ever had mumps in childhood in which there is swollen cheeks or neck glands? Are you taking any medication, any over-the-counter medication, any herbal treatments, or any steroids? Okay, so if he's reluctant and not disclosing anything, then just say that I would like to assure you the confidentiality, and whatever we are going to discuss, it will be confidential. Okay, so may I know why are you taking it and since when are you still taking it? If he has stopped, then ask when did you stop it? So he will show you the muscles. Yes, I can see you have very strong muscles and I appreciate that. So now you have the information that he's taking steroids. Okay, do you have any allergy? Any surgery on your genitals? Any trauma to testes? Any family history of concern? Any genetic condition like cystic fibrosis? Anyone in family with repeated chest infection? Although most likely, like I'm just explaining, in his case, most likely it is steroids, but we just have to exclude few more conditions by asking few questions. That's all. May I know, do you smoke or drink alcohol? If yes, then of course we are smoking and alcohol has no health benefits. We would like to, and they can also interfere with the sperm count. We would like to offer you our NHS Stop and Stop alcohol services. Pardon me to ask any recreational drugs. If he has already told you gym instructor, no need to ask about the occupation again. Any exposure to hot environment, radiation, you take hot baths or wear tight underwear. Have you been feeling low or down lately? And Manu, I can see your weight height ratio is 24. Am I right? Well, how about your partner Lucy? Is she fit and well? And how about her periods? Is it normal? Does she smoke? And may I know her BMI? Okay. All right, so results you have already explained. Fine. Now, what could be the cause of the abnormal sperm count? It can happen because of many causes. Like it can be due to many causes, like infection, some medical or genetic conditions, surgery on genitals or trauma or smoking. But in your case, most likely cause is steroid. Am I clear so far? Steroids have testosterone and which helps to build the muscle, but it can interfere with sperm production and sperm count starts to decline. Like in your case, it went from 10 to 7 million. Eventually, there won't be any sperm if you continue taking it. It can also affect your general health, your heart, liver, and kidney. So giving him information about how steroid can affect the general health, heart, liver, and kidney, this is also important. It is not just about the sperm count. It will hamper his overall health in the long term. All right, so Is it okay if I discuss with you about your management option? First of all, we would advise you to stop these steroids gradually, and for that, we will put you in touch with the hormone and the gland doctor. After stopping, your sperm count will gradually become normal within 3 to 12 months. It takes a very long time for the sperm count to get back to normal after stopping the steroid. In some articles, they have even mentioned 2 years. And we will repeat the test again 3 months after you stop taking them. If next test result is normal, that's good, and it means that steroid is the cause of low sperm count. However, if test comes back the same or even less than 5 million, then we have to offer the hormone test and scan of your genitals. So this one is the severe oligospermia. In that case, we have to offer the hormone test, all the LHF, SH, everything has to be done for him. Now, if there is further low sperm count, then we would like to refer you to the fertility center. One moment. You are already in the subfertility clinic, okay? So I will discuss your case with my consultant first, and then we have to refer you to the fertility center. You are in the fertility clinic. So if you are already in the fertility clinic, first involve your fertility consultant, and then we can refer you to the fertility center. And there you will be offered the options or methods to have baby by artificial techniques. Would you like to know more about them? All right, one is what we call as ICSI. In this, your wife will be given some medications to stimulate her ovary to produce large number of eggs, and the eggs will be collected, and your semen sample will be taken, and good sperms will be selected and injected directly into your wife's eggs to fertilize it. Then fertilized egg will be replaced into your wife's womb to grow into a pregnancy. Another option is the donor sperm. In this, we can use the sperm from donor and inject them into your wife's womb using a syringe. And you can have adoption as a last resort. Any questions? Okay, so I will also be arranging appointment after 3 months' time to assess your sperm count and arrange appointment with the gland doctor and the counselors and discuss your case with my consultant. If you forget to ensure confidentiality in the beginning, you have to talk about confidentiality in this station. Okay? Fine. Who is left? Dr. Maria is there?
Yes, I'm here. Yes, Dr. Shaban.
Yes, okay. Fine. All right. You have done structured discussion before?
Yes, I've done.
Good. All right. Wait. Yeah. Take this one, 2 slides.
Next slide. Okay, I'm ready.
All right, start please.
Hello, I'm Dr. Maria Venati, doctor covering the gynae clinic today. May I confirm your name and age, please?
I'm Kelly Simpson, 36-year-old.
Okay, how may I address you?
Call me Kelly.
Okay, Kelly, I understand you have been referred by your GP is you want to discuss about the fertility preservation options. Uh, I'm going to address your concern, but before this, is it okay if I ask few questions and then we will discuss in detail about the treatment options? Will that be okay?
Yes.
Okay. Okay, so Kelly, can you tell me about your concern in detail? Why do you want this? I mean, why do you want to know about fertility preservation option?
Oh, yes. Actually, I have read about it, and me and my partner, we both are having very busy lives. And I just want to postpone my pregnancy for at least 2 to 3 years. And I would like to have these fertility preservation options, like egg preservation or something like that.
Okay, so Kelly, can you tell me about a few more questions? I would like to know that when was your last period?
10 days ago?
Okay, but your cycle is regular?
Yes.
Okay, are you using any form of contraception currently?
Yeah, I'm taking the pills, the birth control pills.
Okay, and are you updated for cervical screening?
Yes.
Okay. Some personal question I'm asking. Is there any history of sexual sharing infection to you or your partner?
No.
Okay. Are you having regular sex?
Yes.
Any pain or bleeding
No.
during sex?
No.
I can see in your notes that you are fit and fine, but are you taking any medication for any other problem?
No.
Okay. And any allergy from any medicine?
No.
Okay. Any history of surgery? Past surgical history, I mean tummy or down below?
No.
Okay. Do you smoke?
Well, I do, yes.
Do you drink alcohol?
Occasionally.
And what about recreational drug?
No.
Do you?
No.
Okay. So Kelly, I just want to know what are your thoughts about smoking and alcohol? Have you ever tried to quit it?
No, not really.
Okay, so Kelly, you know that smoking as well as alcohol both are not good for health. If you wish, we can connect with our NHS smoking as well as alcohol stop services. So this is also really going to help you. Okay.
Mm-hmm. Okay.
Okay. So Kelly, have you been feeling down or depressed for last few weeks?
No, not at all.
Okay. What do you do for a living?
I'm a busy businesswoman, actually.
Okay. Whom do you live with your
my
partner?
Yes,
Is he supportive?
very supportive.
Good to know. Okay. And are you aware about your weight height ratio? I can see it is 24.2
Yes.
kg
Mhm.
per square.
Yeah.
Okay. Okay, Kelly, coming to your concern, thank you for this full information. May I know, do you have any idea about fertility preservation option?
Not much. I just read little bit about it. I know about the egg preservation, that's all.
Okay. Have you ever visited to any fertility clinic?
No, not yet.
All right. Okay, Kelly, let me tell you, there are the different options. As currently you are living with your partner, so for you, there is one option, embryo preservation, and other is the egg preservation. Basically, in these methods, what we do, we just collect the egg and we just preserve them, I mean, store them, or we just freeze them, okay? Let me tell you about embryo preservation.
Mhm.
What happens that what we do, we just stimulate the ovaries, okay, by some medication. and then ovary will start to produce the eggs, and these eggs will be definitely monitored by ultrasound. Okay, and once ovary will start to make polycalcimine eggs, then we will remove these eggs from the ovaries through the by injecting the needle through the vagina, and we just take out 7 to 14 eggs. Okay, and we then just freeze it and store it. Okay.
Yes.
Uh, uh, and then what we do in embryo preservation, we inject the semen to the egg, and resulting embryo will be replaced in your womb once you are, ready for your family. Okay. So this way we just go for the, embryo preservation. And while egg preservation, there is no need of semen, and there's only need just we take the eggs from you, okay, and method will be the same. Also, in case of the egg embryo preservation, we have need to take consent from you as well as from your partner. While in egg preservation, we just don't have a need of your partner, consent, only your consent will be taken, okay?
Yes.
These are overall safe procedures, but sometimes there are some risk, like during procedure when we stimulate the ovaries, the stimulation of the ovaries may cause the hyperstimulation. And in that situation, what happened, that patient will start to have a vomiting, bloating, and there will be the leakage of the fluid from the vessels. And as a result, there will be the accumulation of the fluid in the tummy and the lungs and in the heart, and that will cause the shortness of breath or difficulty in breathing. We call it ovarian hyperstimulation syndrome in medical terms. And also sometimes there is a risk of multiple pregnancies. Okay. And also there's also risk that patient, we just preserve these eggs or embryo, they may get damaged. Okay. And of course, there are some pregnancy related risks, like patient may have risk of miscarriage. As currently you are 36 years old, so in next few years, if you are going to just ready for the family in 40 years, of course there will be risk of Down syndrome and risk of the high blood pressure, sugar. Okay, so these are also. And for this, of course, we are going to send you a fertility clinic where you will get further guidance. Okay. Clear so far?
Yes, yes. All right.
Okay. And also, I just would like to tell you here that this, preservation can be done for many years. In your case, it can be done for 55 years, but there's a need to renew the consent in every 10 years. Okay. And also, during preservation of any time, especially in the embryo preservation, if your husband withdraw the consent, then you are not supposed to transfer the embryo, okay, because if there's no consent of the husband. All right.
Okay.
So would you like to ask any question, Kelly?
Yes, if I want to withdraw, then what's going to happen to the eggs and embryo?
Yeah, if you are going to withdraw, then you need to inform the center whether you want to discard it or whether you want to donate it to someone else for treatment, or whether you want to use it for research purpose. Okay. So advice, but you have to inform the center.
All right.
Okay, Kelly?
Yes.
So these are the information leaflets. These are also going to help you and guide you further about these options. And also I will give you some contact numbers, support group numbers. Okay. And I'm going to fix your appointment with fertility clinic. And also I'm going to fix your appointment with my consultant. Thank you so much for your time.
Okay. Thank you. All right.
Thank
So
you.
all good one. Good effort. I mean, it was a difficult task when it came for the first time in the exam because there was a new talk. Monica,
Very difficult
it's
for
very,
me, especially
yes,
because I'm
yes.
first
So,
time in all these.
I know
Yeah.
you just started your preparation. So for first timer, it is you need a pat on your back because it was a difficult because if you are not you don't read about the fertility preservation options, it's very difficult to say the important points in the exam. We know about egg preservation and embryo preservation in general, but how to say the important points that is very, very important. So overall,
Right.
fine. Yes. She and her partner are otherwise medically fit and well. Yes. So both of them medically fit and well. All the tests were done. So good. And a few points we will discuss that, but just we also have to offer these tests. Okay. Never forget these tests, because these were not done. Okay. Tests to assess the number and quality of eggs in your ovaries, the blood test, the hormones, and the scans. And screening for infection is very, very important. We have to check for the hepatitis, HIV, so that eggs and embryos can be preserved in correct place to avoid any contamination. Then there are some important points in the history. We are going to have a look at that. This is all from the talk which I have taken. Fine. Okay, let's discuss the answer. So you're under gynae clinic. Your patient is Kelly. Hello, Kelly. I understand you have been referred by your GP as you want to discuss about the fertility preservation options. Am I right? Is there any other concern and expectations from today's meeting? So in a moment, I'll try to address all your concerns. Before that, is it okay if I ask a few questions, then discuss the fertility preservation options and further management plan? Will that be okay? And I shall also give the patient information leaflet about the options available for you. So can you tell me more about your concerns or what brings you here? I do appreciate your concerns. And I can see that you are otherwise medically fit and well. May I know when was your last periods? When was your last periods and how are your periods otherwise? What was your age when you had the periods for the first time? Asking about the menarche is also important. And any pain during the periods, updated with your cervical screening? Have you been using any contraception? Would like to ask you some personal questions. Any problem during the sex, you and your partner, were you ever treated for any sexually shared infection? If anyway, here you can also ask, are you sexually active? We don't know why she wants to preserve her ex. Maybe she just is a single lady and she is not having any partner. So yes, I would like to know whether you are are you with someone now and are you sexually active? Okay. If she gives all this information in the very beginning that I'm a very busy businesswoman, my partner is also very busy person, and that is why we are not at the moment prepared to start the family, and I want to know about the fertility preservation options. So now here she has given you a lot of information. She told you about her occupation. She's having a very busy life and she has a partner. In that case, don't ask, may I know, are you with someone now and are you sexually active? Okay, she already gave you a lot of information in the beginning. Okay, then may I know, okay, fit and well, you've asked, are you on any medication, any allergy, any surgery on your tummy or down below, any family history of concern like early menopause, any fertility issues, delay in conceiving, any history of cancer of the womb or the ovary. And may I know what you do for a living? Okay, so do you also have to travel to area? Have you traveled to any area recently without break of infectious disease? Now, this question is given in the talk, and they have explained that we have to screen for that infectious disease first and treat her if she's having that condition. That is why it is important to know. How about your partner and support? Do you and your partner, do you smoke or drink alcohol? Pardon me to ask, any recreational drugs? So smoking and alcohol has got no health benefits and it can even affect the fertility and eggs. So we would like you to put you in touch with our Stop Smoking and Stop Alcohol services. Will that be okay? Fine. Have you been feeling lower down lately? No. I can see your BMI is 24.3. Is it okay? Am I right? Thanks for these informations. Would you like to add anything important? Now, coming to your concerns, do you have an idea about the fertility preservation? Yes, there are options for like many options, and in your case, the Like we can offer you the embryo preservation, that is the preservation of the babies, and the egg preservation. It means freezing of embryo or egg in a suitable environment, and you can use them when you are ready to start your family. Just keep in mind what you have to discuss in this station. You have to discuss the details of both the procedures, refer to the fertility center if you're in the gynae clinic. Consent of partner is very important in embryo preservation. So you have to keep this in mind. So coming to the embryo preservation, you will be given some medications to stimulate your ovary. They will produce large number of eggs and it takes about 2 to 3 weeks time. Monitoring will be done by the scan from down below to assess that eggs are produced or not. This will be done by the scan specialist. Around 7 to 14 eggs are collected by inserting a needle through your vagina. These eggs will be injected with your partner's semen and resulting embryos, that is, babies, will be frozen and stored. Fast freezing is done, and when you are ready to start your family, these embryos will be transferred into your womb. There is a very important legal issue, that is, partner's consent is a must for this. If any time your partner withdraws the consent, then you can't use the embryo. Any questions? So what the talk says that this fast freezing, vitrification, before it was slow freezing. So with the fast freezing, the advantage is that there is no formation of the ice crystals in the egg. So that is why they are doing the fast freezing techniques nowadays. Then coming to the egg cryopreservation, procedure is done in the same way as embryo preservation, but here only your eggs are collected, partner semen is not needed. Fast freezing is done and eggs are stored and only your consent is needed. But when your eggs are ready to, when you are ready to start your family, then eggs will be injected by your partner's semen. And here, yes, we have to take your partner's consent to get his semen, but not for the egg preservation. What are the risks? Generally, these are safe procedures done by fertility experts, but there are some risks with the medications and injections given. They can cause overstimulation of ovaries. Ovaries will produce large number of eggs. This can cause tummy pain, bloating, nausea, and vomiting. Sometimes there can be fluid collection in tummy or around the heart and lungs, condition which is known as ovarian hyperstimulation syndrome. However, for this condition, treatment is available. But at times, if there is severe symptoms because of this OHSS, then cycle has to be cancelled, eggs may not be collected, and embryos may not be formed. Am I clear so far? Any questions? Also, there is risk of failure because eggs or embryo may get damaged during the preservation. And also we have seen that there can be pregnancy complication in women who get pregnant in advancing age, like there can be risk of miscarriage, medical problems like diabetes and hypertension. Talk in general. It is a good idea to talk in general that we have seen in women who get pregnant with advancing age. Avoid saying you in your case. So because this is a good idea. This is what we were taught, that this is how like the council even in the NHS talk in general about the advancing age. Now, there are some tests which we will offer to assess the number and quality of eggs in your ovaries. This is the ovarian reserve, the blood test to check for the hormones, and some scans to check the eggs in your ovary. Okay. Now, with advancing age, number of eggs become less and quality deteriorates. We will offer screening for infection, check for infection like hepatitis and HIV so that eggs or embryos can be preserved in correct place to avoid contamination. All right. What about the funding, doctor? May not be funded in your case because you are medically fit and well. Funding depends upon the place you live in, and you can talk to your GP about the funding. He or she in turn will discuss with the Integrated Care Board regarding funding. Now, there is no clinical commissioning group. It has been replaced by the Integrated Care Board. Now, doctor, if anytime I want to discontinue storage, then what I have to do? Yes, in that case, you will inform your center and you have to inform what to do with the unused eggs or embryos. They can be discarded or donated to someone for treatment or used in research purpose. How long can I store my eggs? Okay, for 55 years, and renew the consent every 10 years. For the egg preservation, only your consent is required, and for embryo preservation, both your and your partner's consent is needed. Any questions? All right. So I will also be writing back to the GP about our care plan and arrange appointment with my consultant in few weeks' time, give you the contact number. And next visit, you can come with your partner. Any more questions? Okay. In the beginning, yes, you can add that line. Even I forgot to write and say that. I can see that you have come alone. Come alone. May I know where is your partner? So next visit, come with your partner. We would be happy to see you both together. Well done. Okay. One more structure discussion I have. Someone has to volunteer. Yes, who will take the structure discussion? Who would like?
I can.
Yes, well done. Come, please. Okay.
Yes.
This one we have done. Yeah, take your 2 minutes.
Yeah. Next paper, please.
Yes.
Yeah. Next slide.
Mhm.
Yeah. Can I start?
Yes, start, please. Okay.
Yes. The picture one, please. Picture
It-
slide.
oh, yes, yes. Yeah, okay.
Okay. Yeah. Next one. Yes. I am Sweta. I have read the instructions and ready for structure discussion.
Okay, so can you explain the picture?
Yeah, the scan. My patient is Anna Parker, 30 years old, and the scan report has been given to me. Pelvic scan report has been given to me. It shows that uh, both right and left ovary picture is there, and it shows that there are multiple follicles arranged in a pearl of necklace pattern, and they are multiple in number, more than, it seems to be more than 12 in number, and diameter is less than 10 mm. So this seems to be a case of polycystic ovaries. And the next picture is a picture of hysterosalpingogram, and the right and left tube seems to be open because spillage of dye is there in both sides, and on the top of uterus there is a dip. So it could be arcuate uterus or it could be a septate uterus. So I will discuss about it with my consultant as well as to the radiologist. And regarding the hormone finding, and all the FSH, LH, prolactin, testosterone, estradiol all seems to be normal, and but progesterone is low. This shows that there is ovulation is not happening, and it is day 21 progesterone. So ovulation is not happening as well, and the semen parameter are all normal, and the her she has come with complaint of irregular period for she has come with complaint of irregular period, which comes every 3 to 4 months, and she has mild hirsutism and acne, and corresponding with correlating with all these scan finding and hormonal findings. So she could be a case of polycystic ovarian syndrome.
Right.
So regarding the management of this couple, I'll take detailed history. I'll examine her and send in necessary investigation if needed, and then manage according to the protocol. So regarding her history, I would like to ask about her complaint, like her complaint, like how long she has been planning for pregnancy in detail, any treatment taken earlier and any investigation done earlier as well or not. And then regarding her periods, her menstrual cycle, since when she is having this problem in detail. Then also regarding her last menstrual period, I will ask, and then smear history I'll take, and then I'll check that if she is taking any contraception. After that, I'll take obstetric history as well. And regarding her partner also, like previously, if he has fathered any children or not. Then I'll take her medical history, any other medical comorbidity like thyroid, diabetes, and any heart problem, bone problem, or any sleep apnea if she has. Then regarding her partner history, as I can see that he is fit and healthy. So I'll like to ask about her sexual history after signposting, that is there any problem with sexual intercourse or not. And then any sexually shared infection, I'll also rule out. And after that, I'll rule out allergy and any medicine they have been taking for any other reason. Then personal history, then like smoking, alcohol, and any recreational drugs for both of them. And her BMI also, BMI of her is, I can see that her partner has BMI of 22, and her also 25, so both are in range. So, and after that, I'll see that how is the support at home and her mental status, because she has been planning for pregnancy for long. And then I'll examine her regarding the keeping polycystic ovary syndrome in my mind. So I'll general blood pressure and then skin condition like any acanthosis nigricans if she has. Then after that, I'll explain her condition, that what are the implications of polycystic ovary. Does she know about the polycystic ovary and consequences or not? Then after explanation, then I'll manage her regarding taking help of MDT, multidisciplinary team like consultant gynecologists, fertility specialist nurse, and then radiologist would also be involved. In that. Then after that, regarding her management, lifestyle modification, first of all, I'll tell her that it is very important that if she smokes, then stopping smoking, alcohol, and taking care of her health is very important. If in her case BMI is normal, but doing proper exercise, proper diet has important role in the management. Then regarding her medical management, I will go for first of all, ovulation induction would be done with medicine, and if medicine doesn't work, then injectable gonadotropin, and after that laparoscopic ovarian drilling can be done. If ovulation induction fails, then after that IVF and adoption can also be advice to her. So regarding her medical management, first of all, I'll start with clomiphene citrate. Clomiphene citrate is anti-estrogen, and it would be started with the lowest dose, like 50 milligram from day 2 to day 6, and it is given from the lowest dose as well. So, however, it has side effects. So I'll explain her that if she can have mood changes, she can have nausea, vomit, and also some vision problems she can have with clomiphene citrate. And also if this it can be given for 6 months, but if we see that after 3 months it has not ovulation is not happening, then in that case metformin can be started. Dose of metformin could be from 500 milligram to 2500 milligram. It can cause like nausea, vomit, bloatedness, diarrhea. It can side effect of this. So total of 6 cycles of with clomiphene citrate it can be given. After that, if doesn't work, then laparoscopic ovarian drilling can be done if in a patient where BMI is normal. Her BMI is normal, so it can be given. It can be given in her case. So this is done with a it is a laparoscopic surgery, so keyhole surgery, and the ovaries would be punctured at 4 places with 40 watt for 4 seconds. So it decreases the ovarian stromal volume so that LH and testosterone are balanced. And if this does and as this is a surgery, so there are risk of surgery, anesthesia, injury to other organ can happen, infection can happen with that. So if this doesn't work, then we can move to injectable gonadotropin, and it can be started from, it can be done with a step-up process, like start with low dose and go to the high dose. And it has side effect of like ovarian hyperstimulation syndrome, and multiple pregnancy can happen with that. So patient would be explained regarding the complications. And after that, if all these fails, then IVF would refer her to the fertility center for IVF and procedure and adoption. She can go for that. Yes, in this way, I will manage my patient.
Okay. And are you going to offer her hysteroscopy?
Yes, regarding her in hysterosalpingogram, I can see that there is a dip on the top of uterus. So it could be due to arcate uterus or septum. So I need hysteroscopy for that to see from the inside. So if it is arcate uterus, that would not cause much problem. But if septum is there, mild septum is also not responsible for her fertility. But if it is thick septum is there and full septum is there, then there could be that can be a cause. However, the evidence is doesn't say that removal improves the fertility.
Okay. Good. Just 40 seconds. Okay.
So, yes.
I think you have.
Yeah. In her case, I'd like to if I'll ask about her LMP, and because she has
Yes.
irregular periods, so I'll rule out her pregnancy. So urine pregnancy test I'd offer, and then she's PCO in polycystic ovary syndrome. We advise to go for OGTT done because he is at high risk of having diabetes, and also cardiovascular problem can happen, cardiometabolic problem can happen. So lipid profile can be done. And polycystic ovary syndrome has long-term complication as well, like diabetes, like sleep apnea, and any cardiovascular problem can happen later on. So we'll keep monitoring her regarding that also.
Yes.
She will be explained.
Exactly. And withdrawal bleed before starting the clomiphene citrate.
Yes, I forgot.
Yes.
I forgot that.
Small point. Yes. Pregnancy test, if negative, withdrawal bleed, and then all the medications. And yes, we have to inform her about the long-term implications of PCOS.
Yes.
Good. So don't forget those points. Okay. Yeah. All right. So you have to discuss the picture first. So just you will see, you have to confirm the patient's name, date of birth. Okay. Describe what you are going to see, the name of the test, and when it was done. Okay. So the first picture, this is a picture of pelvic ultrasound scan done for Sarah Parker, 30-year-old, and it was done on 5/2/24, and it shows both right and left ovaries with multiple follicles in both of them, and they are arranged as pearl of necklace pattern in the periphery. So this is picture of polycystic ovaries, and in polycystic ovaries, actually there are 12 or more follicles and 2 to 9 millimeter in diameter. Next picture is that of hysterosalpingogram done for the same patient, Sarah Parker, and it shows uterus and the tubes. Both tubes appear patent. due to spillage of dye on both sides. Uterine cavity appears like there is an indentation or dip, and it appears as an arcuate or septate uterus. So to confirm the findings, I would consult my consultant and radiologist. So communication with colleague and also patient safety. If any doubt, I'm going to consult with my consultant and radiologist. All right, now what is your diagnosis? So you have to correlate everything as per the patient's history. Like from the history, I can see patient is having oligomenorrhea, hirsutism, acne, and like ultrasound is showing polycystic ovaries. So, and from also the investigation is given, semen analysis is normal, but day 21 progesterone is less, it is only 2. So most likely this patient is having anovulatory subfertility due to polycystic ovarian syndrome. And PCOS is diagnosed by Rotterdam criteria, in which 2 out of 3 criteria has to be present. All right, now how will you manage this patient? So yes, management is history, examination, investigation, management. So I will take the detailed history from this, from the patient, from the couple. So whether they have any child and did they take any treatment before. Gyne history is important. I would like to know about the last menstrual period. So as she's having irregular cycles, and from the notes, I can see that, okay, they have not mentioned the LMP. So she's having irregular periods every 3 to 4 months. So I would like to know the last menstrual period as well. And then, yes, ops history. I would like to know whether they have any child, whether the partner or they have any child. And sexual history, I would ask after signposting whether they are having regular sexual intercourse, they are aware of the fertility period, whether there is any history of sexually shared infection, any problem during the sex. Then about the medical history, and if they are having any medical condition like diabetes, hypertension, whether they are on any medication, whether the patient, she has started taking folic acid, any allergy, and any surgery. And if they smoke or drink alcohol, then I have to advise regarding stopping smoking and stopping alcohol services, and would like to know if they have taken recreational drugs, which has to be stopped as well. I would like to know about the mental health status, whether there is any low mood or depression. If so, then put them in touch with the counselors or the psychologist. And in my patient, I would like to know whether she's having any sleep apnea, what about the support at home, and whether the partner is fit and healthy. So I would like to examine the patient with a permission in the presence of chaperone, check for the blood. I would like to know her blood pressure as well, whether there's any skin changes like acanthosis nigricans. Then offer investigations as the periods are irregular, so urine pregnancy test to rule out pregnancy. She's at risk of type 2 DM, so OGTT for screening of type 2 DM, and lipid profile to rule out metabolic syndrome. So history, examination, investigations, you will not forget. Just go step by step. Then coming to the management. I will explain the diagnosis to her, and we can offer the lifestyle modifications and then discuss the methods for induction of ovulation. So simple measures like eating a healthy balanced diet to maintain her weight. For that, we can refer to the dietitian. She will continue taking folic acid if she's taking it. Rubella testing is important, whether she's rubella immune or not. Then for an ovulation or for induction of ovulation, so first I will exclude pregnancy, then offer the progestogen for withdrawal bleeding. Medications given can be medroxyprogesterone acetate or norethisterne. And drug of choice for induction of ovulation is clomiphene citrate. Dose is 50 milligram once daily for 5 days from day 2 to day 6 of cycle. Monitoring by serial scans for follicle tracking is important because there is risk of multiple pregnancy and very small risk of OHSS. Dose adjustment will be done as per the response. So dose can be kept same or increased to 100 milligram per day if less response is there, or decreased to 25 milligram per day if there is more response. Clomiphene is given only for 6 cycles. These are the important points, important patient safety points, which are in red and asterisks. Okay. What about the success rate? So ovulation induction can happen in 70 to 80%. Pregnancy rate is 60%. Side effects, patient can have nausea, vomiting, abdominal pain, hot flushes, because it is anti-estrogenic side effect of this medication, mood swings, visual disturbances. So if she has visual disturbance, then clomiphene has to be stopped right away. This is very serious side effect, and that is the patient safety. Who will prescribe clomiphene citrate? Fertility specialist. And when are we going to add metformin? If there is no response with clomiphene for 3 months, then metformin may be added for another 3 months, and the dose is 500 milligram once daily, maximum 2500 milligram a day. Side effects, we know it causes severe gastritis, so it can cause nausea, vomiting, gastritis, bloating, diarrhea, constipation. Then we can offer the patient either laparoscopic drilling or injection gonadotrophin. So in my patient, the BMI is normal, so we can offer laparoscopic drilling, particularly if patient needs laparoscopy for other indication as well. Done by trained laparoscopic surgeon under general anesthesia, and these 4 punctures are given in each ovary with a depth of 4 millimeter. Volt used, that is energy used is 40 volt, given for 4 seconds. What about the risk? There is risk of surgery and anesthesia, damage to bowel, bladder, blood vessel, pain, infection. There can be additions, and it may adversely affect the reproductive capacity of ovaries in future. But what are the benefits? No risk of OHSS and multiple pregnancy. Doesn't need ultrasound monitoring of follicles. It helps to normalize the LH and testosterone level and sex hormone binding globulin level as well. Gonadotropin injections. So if you remember, even you can just say that there are different regimes, step up and step down, and sequential regime. So what we do that usually step up regime is done. In this, we start with the low dose. So it will decrease the risk of OHSS and multiple pregnancy. Although with the low dose, it will take time, but it is safer. What are the preparations? Human menopausal gonadotropin, recombinant FSH, GnRH, NO. Then discuss the pros and cons. So it will need the serial scan for follicular tracking. What are the benefits? No risk of surgery and anesthesia, but there are risks of OHSS and multiple pregnancy. If medical treatment fails, then other options are IVF with donor oocytes and adoption. Also, we have to inform the patient about the risk of long-term implications of a condition like diabetes, hypertension, cardiometabolic syndrome, endometrial hyperplasia, endometrial cancer, and during the pregnancy, there is risk of miscarriage. Just a minute. Okay. There is risk of miscarriage, GDM, PIH, preeclampsia, and preterm birth. I will also give the patient information leaflet about her condition and give her the support group numbers. Are you going to offer her hysteroscopy? So from the hysterosalpingogram, as I can see that there is some indentation. So I have to offer hysteroscopy to visualize the uterine cavity and to confirm the presence of septum. If there is mild septum, it may not cause problem with fertility, but large or big septum can cause problems. But still, hysteroscopic removal of the septum is debatable. The evidence is inconclusive whether removal of septum will improve the fertility or not, and it needs advice from the expert, or like I will discuss this with my consultant and the expert. Okay, so this is how I'm going to manage this case. Anything else? No, we are done with all the stations today. All right, any questions? Okay.
No, very clear.
Very clear. Okay, thank you. Thanks to all of you as well. You people are working hard. Yes, I can make out because all of you are performing very well, and it really makes my life easy as well. Very nice. All of you are doing great, and I really hope and pray that you all pass this exam this time. So next will be the sexual and reproductive health module. We will meet at the same time. Thursday it will be for us. All right. Okay. Good night, all of you.